Good afternoon. I'm Kimberly Northrup from CE Central. I would like to make a few announcements before we start. I have muted everyone's microphone. Actually, Kenny did that. Please ask questions via the Q&A function. At the end of the talk, I will read as many of them as I can for Dr. White to answer. I will also display the credit code right now and at the end of the talk. Today, our speaker is Dr. Connie White. Dr. White practices as an OBGYN in Frankfort, Kentucky for over 20 years. She retired from clinical medicine and first worked at the Kentucky Department for Public Health as the director of the Division of Women's Health from 2009 to 2010. She then joined the College of Public Health as a clinical professor at the University of Kentucky from 2011 to 2012 in the Department for Health Behavior. Dr. White returned to the Kentucky Department of Public Health as Deputy Commissioner in 2014. She has served as the principal investigator for several grants that include diabetes, heart disease and stroke, colon cancer screening, medication for opioid use disorder for pregnant and parenting women, and obesity, physical activity, among others. She completed medical school training at the University of Kentucky and an OBGYN residency at the University of Louisville. She is certified in OBGYN by the American Board of Obstetrics and Gynecology. Dr. White will give a talk entitled Cancer and the COVID-19 Realities. Please welcome Dr. White.
Hello, thank you, Dr. Northup. I appreciate your kind invitation to come in today. We are glad that the Department for Public Health is welcome at your grand rounds. And I'd love to come here telling you that I have all kinds of answers for you. But since this is a novel virus and we know very little about it, we have probably more questions and the data is pretty sparse. But I would like to share with you the statewide public health response and talk to you about how we're all going to be able to get through this. Sorry, I'm sharing my screen now. There we go. Okay.
Perfect, Connie. Thank you so much. Go ahead.
Okay. So objectives, when I wrote these objectives a couple of weeks ago, the world has changed. In fact, things around here have been changing about sometimes twice a day as we've been working on this COVID-19 virus. We will talk about public health policy. We'll talk about what we do know about science, the science of cancer and COVID-19. And when I first thought about writing these objectives, I was going to help you to try to help your patients get through the uncertainty of what's going to happen with their cancer treatment now that we are in a state lockdown for medical treatment. Well, as of yesterday afternoon, that has changed. So I had to change my objectives. So the objective now is not helping them get through this pandemic and the delay emotionally, but trying to help them understand how things will reopen and how they'll be able to have their cancer care completed. This is the obligatory org chart that you always throw everyone when they're talking about a new organization that you might not be familiar with. There are a lot of programs here in the Department for Public Health, and we have 7 divisions. You may have heard of the breast and cervical cancer screening program, our colon cancer screening program. A lot of these programs you will not have ever heard of, and we sometimes say that public health is the best kept community secret, and nobody really knows about us unless there's a disaster getting ready to happen. The other part of our public health team are our local health departments. And here's a map here that shows the white counties are individual health departments for one county. And then the colored ones show that some of these counties have bonded together as districts. And this is how our organization works. Both the local health departments and the State Department for Public Health, or DPH, have a similar mission and our similar vision. And our mission is to improve the health of Kentucky and the safety of the people of Kentucky through prevention, promotion, and protection. So you can think of it as we are trying to prevent this virus spread. We're trying to protect the healthcare community with trying to allow people to get access to PPE, laboratory testing, trying to help people protect themselves by getting the right data so they can make data-driven decisions, and then also to promote these protections until we can get a vaccine that will help us to better fight this. If anyone's ever heard me talk, I always like to include a bit of history, and that bad boy right there is what really helped to put public health on the map. Back during the 1854 outbreak of cholera in Soho in London. Now, I don't know if any of you know John Snow. No, not that John Snow, but that John Snow. John Snow was a physician in London during the cholera outbreak. Back then, we didn't really know how people got cholera, but he was very interested in trying to figure out why some people got cholera and some people didn't. So he pretty much invented epidemiology when he discovered what he thought was the source of that cholera outbreak, which was the Broad Street pump. This map right here is where Dr. Snow meticulously went from house to house to house around the Broad Street pump. Well, I don't know what I just did, but let's try this again. Just do that, okay. So this map shows you where the Broad Street pump, where that blue circle is, and all those black squares are when he went from house to house and asked how many people had cholera. It's interesting, if you see on the right, there's a square there where no one had cholera in that square, and that happened to be the square where the brewery was. And when they took the water from the Broad Street pump and they put it through the brewery, it killed all the cholera and nobody around there got sick. And that was his way of figuring out how cholera was spreading in London. This shows the CDC's top 10 great achievements for public health. All of those things that you see listed there have changed the landscape of what our life expectancy is. It has also changed not only how long we live, but the quality of life that we have. So public health looks at preventing diseases in a population, and while medicine looks at treating the diseases and the individuals that have those illnesses. So I've kind of spanned my career of 20 years doing OBGYN and now 10 years here in the Department of Public Health. The best way I can describe exactly what public health is the story of the three sisters. There were three sisters that were taking a walk along the river one day, and one of the sisters looked over and said, "Oh my goodness, there's a baby in the river." So she jumped into the river and grabbed hold of the baby, and the second sister helped her pull the baby out, and they dried that baby off, and the sister said, "Oh my goodness, look, there's another baby in the river." And so the first sister jumped in and got that baby out. And then there was another baby in the river. By then a crowd had gathered and they were all trying to take care of these babies and make sure they were warm and dried off. And then there was a fourth baby in the river. And as they were resuscitating these babies, they looked around and couldn't find their third sister. And they saw her up way away from them walking along the river. And someone said, "Why aren't you here helping us?" And she said, "I'm going up the river to find out who's throwing babies in the river." So that's where public health is. While you guys are on the front lines and working carefully to make sure these babies are surviving, the public health structure is to try to figure out who's throwing these babies in the river to start with. So we think of it as 3 levels of prevention. There's preventing people from getting a disease, such as trying to prevent them from catching the COVID-19 virus. There's secondary prevention, which is trying to catch that disease early, trying to prevent it from spreading by contact tracing, and we'll talk about that in a minute. And then the tertiary prevention is trying to be sure that the people on the front line have the tools that they need, the ventilators they need, the PPE that they need, the things that they need to try to prevent these people from dying or succumbing to their COVID-19 virus. This is one of the main reasons that I'm here today, because on March the 18th, there was an executive order by the governor that closed down everything that we knew as our jobs, unless you're working in the emergency field and you're working with acute care. And that was that we couldn't do any non-emergent, non-urgent, in-person medical, surgical, dental, or other healthcare practices. The part that I think was most important that a lot of people missed is number 4. And number 4 says, when you look at this guidance, you have to consider whether the service you're providing in retrospect would still be deemed necessary if that patient or a close contact of that patient became infected with COVID-19 as a result and suffered serious or irreparable harm as a result. This isn't anything new to oncologists. You live your life in that art of medicine of trying to decide what's that risk-benefit ratio. That's what you do every day with your patients. And this is what we were asking the general public. It wasn't lock your doors and go home and pull the cover over your head. It was, as most of you have been doing, you have oncology patients that depend on you for their life, and you're always in that balance. So I tried to look for some literature to give you what we do know, and I went to the Society of Clinical Oncologists and found a really nice paper from the WHO and the China Joint Mission on Coronavirus Disease. It was a very small study, but it's what they had at the time. It was published in February. And they found in their study that of the patients who had the overall population, there was a 3.8% morbidity with this, fatality with this cancer. And it varied depending on the morbidity. So if you were a cancer patient, there was a 7.6% chance of mortality, whereas the overall population was, as I said, was 3.8. If you had no comorbidities at all, it was 1.4. If you had cardiovascular disease, you were in trouble. You had a 13.2% morbidity rate, diabetes 9.2, hypertension 8.4, and chronic respiratory disease, the comorbidities were 8. This is another paper that was published in the Lancet in March, where they looked at, again, a small number. Of this volume, they only had 18 patients that were cancer patients, and 5 of them were lung cancer, and the others were just a smattering of different types of primary cancers. And on the left-hand side, you see the bar graphs. The two colored bars have to do with how they were diagnosed with their illnesses. But if you just look at the overall trend, you can see that if the patient did not have cancer, that's the left-sided pink and blue bar, and the incidence of severe events versus their cancer survivors. And these were people that had not had any kind of treatment for several months, or then their third set of bars were people that were actively being treated for their cancer. So you can see that there was more of a progression if you were in active treatment for cancer. And that shows up on the right-hand side of the screen, where they showed the blue lines are patients without cancer, and the green line is patients with cancer and the probability of a severe event. So that last Lancet article came up with 3 recommendations. They recommended that you intentionally postpone adjuvant chemotherapy or elective surgery if you're in an endemic area of COVID-19. The second one shows that you should have stronger personal protective provisions for patients who were cancer patients. And then the third one was that you should do more surveillance and treatment with patients who have cancer that are infected with COVID-19, especially if they're older and they had other comorbidities. I think we already know all of those things, but that was what was published in the article. This is a slide that I kind of called the duh slide. It was some recommendations I saw for one paper, and you should tell your patients what the symptoms of COVID-19 are. I think most of you probably have already done that. It's been very interesting as we've been seeing outbreaks in nursing homes. It's not the fever, cough, and shortness of breath that we're seeing as much as the myalgias, and more importantly, the GI diagnoses. We just had a nursing home yesterday that diagnosed their first patient, and it was a patient with a new onset of diarrhea, and the medical director ordered a COVID-19 test on that patient, and it was positive. You should train your patients with proper hand washing, hygiene, and minimizing exposure to sick crowds. I think that's something you're already doing. The general cloth mask and what you should wear in public, I think that's something you probably talk to your patients about during flu season anyway, but now the recommendation about wearing some kind of face covering to try to prevent spread is becoming more common in the United States as it's never been before. And then always, if the patient has a fever, you work them up. So I didn't think these guidelines, when I read them, I thought everybody in the room is going to know this, but these were the recommendations that I could find. You do want to be sure, at least in my opinion, N95s, when I see somebody out walking in Kroger's wearing an N95, my first question is, where did they get one? Because that's some pretty precious property to have. But I don't know if I did not see that as any kind of a recommendation anywhere. So I think the surgical masks or the cloth masks are the recommendation. Now, delaying treatment of cancer. I'm not going to go into this like I was going to go into it before, because now we're going to be able to open that up. but it just talked about, again, that risk-benefit world that you live in. If you continue the treatment, is it going to immunosuppress your patients and make them more likely to have COVID-19? The treatment shouldn't be resumed until the symptoms of COVID-19 resolve if the patient happens to have COVID-19. The recommendation about a negative PCR test is, in my mind, a little bit of a controversy. We know this test can be sensitive, so if it's positive after you've resolved your symptoms, is that just some pieces of RNA that's left behind? Does that mean that you're infected? I think we're recommending now that people go by symptoms rather than negative testing. And then you have that balance you have to make as to whether the cancer is progressing rapidly. And then CDC has their list of recommendations. Same thing with surgery. You are recommended by the American College of Surgeons to follow their guidance and cancel elective surgeries. Unless you determine there's potential harm, well, then it's not elective anymore. So you should go ahead and do that for your patient. But the piece that I thought was interesting is to be sure that if you are in a high area of COVID-19, that you do have the OR and the potential ICU support that you might need on that particular patient. There's a lot of conversation about neoadjuvant therapy, and I know I've read some about in breast cancer, in the early stage breast cancer, if you can do this and delay surgery for a while. Again, that's that balancing act of you deciding, is this tumor progressing to the point that you need to be doing something different and going ahead and balancing the immunosuppressive risk with stopping that treatment for your patient. A little bit about radiation. It was recommended that you look at hypofractionation if that's possible. Delaying the treatment for patients, balancing that with, is that going to be something that's going to be harmful to them? And then not consider doing radiation for people for symptom control and low risk. Immunosuppressive therapy, I think we've already covered that you have to balance. Are you going to immunosuppress them and make them more susceptible to COVID-19, or are they in a place where they need that therapy? And that's your balancing act to make. And then you ought to think about doing COVID-19 testing on potential donors for stem cell transplantation. Okay, so now let's talk about Kentucky and where we are right now. This is a map. This is from yesterday. It is on our website. I'll show you the website link. If you haven't been there, I think you'll find a lot of information. We are trying to keep it updated and make sure that we don't have, as I said, this is evolving so quickly. We want to make sure we don't have old data there for you. But this is showing you the numbers of positive COVID-19 tests. It's not surprising to see the darker counties, the higher numbers in northern Kentucky across from Cincinnati, Jefferson County, Fayette County, but you're seeing a lot of cases happening in western Kentucky. The next map is a map that's just been put up on our website, and this is our rate map, which gives you a little bit different picture because you're seeing higher rates in Hopkins County, Muhlenberg, Butler, Lyon, Graves. Part of that has to do with, in Hopkins County, they had the week before our first case was diagnosed, or maybe the first week of the diagnosis, a revival. They had about 40 cases of COVID-19 of people that attended that revival and 6 deaths. The other thing that's happened in Hopkins County is they've had an outbreak in long-term care facility. You'll see that in Adair and Jackson and Graves, where there are higher numbers than you might anticipate because of those outbreaks in those long-term care facilities. This is the dashboard off of our website, which gives you our current number. I took this off last night. So there's our confirmed cases, the differentiation by gender, the total numbers of deaths, the sex by gender, the deaths by gender, sorry, confirmed cases by age group, confirmed deaths by age group, what we call the epi curve. Now you're going to see very, very small in April, but that's because this epi curve shows you where the illness began. So those last couple of weeks, you may not see those numbers graphed on that on the bar graph because those illnesses have not been diagnosed yet. The map, if you hover your pointer over each of those counties, it will tell you the number of deaths in that county. It'll tell you the number of cases in that county. It will give you that county population. And if you go to the rate map, it will also tell you the rate for that individual county. And then on the right-hand side, you can go to scroll down and look at each individual county for their numbers of cases. You hear a lot about people saying, well, one county says they've got this number and the governor says a different number, and what's that all about? The governor's taking numbers from us as they're reported to us, and sometimes we will report the numbers we have, and then we'll go back and scrub the data and realize that somebody we were told that this person was from Connie County, and actually they work in Connie County. That's where they got their test done, but they live in White County. So we have to go through and make sure that data is scrubbed. Sometimes it will say Connie White on the test, and a different report will come in CG White. And so we have to make sure that we get rid of duplicates. So it is a huge process. We've got about 30 different laboratories that we're getting data reported from in all of our health departments. And and then there's the University of Facebook. People are always trying to report things to us. We try not to report things unless we have confirmed that we are sure that these are cases. We have sometimes people living, working in Louisville, but they actually live in Indiana. That's an Indiana case. What if you're going to school in Louisiana, but you came home from spring break in a different county in Kentucky and you were diagnosed in Kentucky? Are you a Kentucky case? Are you a Louisiana case? All those things that are very minuscule kind of details make a difference when you're looking at your total count. This is a slide that's very troubling to me. This shows you the Kentucky population by race and ethnicity. That's the blue bar. The red bar are the number of COVID-19 cases that we have. And then the green bar, the bottom bar, is the number of deaths. And the thing that's most concerning to all of us, not only in Kentucky, but across the nation, is that we have about a population of 8 to 9% African Americans in Kentucky, but 13% of our cases and 18% of our deaths are in that population. Just in the last day, we've got those mapped out. We know where those people lived, and we are getting ready to target some drive-through testing sites in the areas where the majority of those people are found. I like this slide because it shows that social distancing in Kentucky works. In this slide on the blue bars, those are our cases of influenza that were reported to the State Department for Public Health of first, second, third, fourth week of March last year and the first week of April. The flu season wasn't that robust last year, and you can see that decline over the month of March and that first week of April. However, the orange bars are what happened this year. We had a very aggressive flu season this year, and you can see that that line just went down like a rock when social distancing was started in Kentucky. So it does show us that the effects of the work and that the Kentucky citizenry has done to socially distance themselves and be healthy at home, decrease the rate of flu, of onset of flu, and we feel it did the same thing for COVID-19. These two graphs come from a website called 91DIVOC, which is COVID-19 spelled backwards. And I like graphs. I like the way it just, shows you what's happening in different states. So in the top left, I picked Tennessee, and the bottom right, I picked Ohio, just because they're border states. And then you can see Washington right above Tennessee, that light purple line for reference. And here is Kentucky. So you can kind of compare those three states, not picking on them for any particular reason, but one's above us and one's below us. And I wanted you to kind of see where Kentucky was with confirmed cases. Now, confirmed cases depends on how much testing you're doing. So I also wanted to pull up that you can on this website look at deaths. Again, that faint purple line that goes all the way out to the right side of the graph is Washington State. So you can see Tennessee and Ohio there, and then you can see where Kentucky lands in that area. So that gives you just something to compare to. So you can go to that website, you can pick different countries, or you can pick different states to look at. This is interesting when you're looking at what are we going to do when the White House instructions say we need to have a decline over 14 days. And this is how you can look at statistics, and you can change statistics around to lots of different things. This shows what a linear progression would look like. And this shows what it would look like if you're looking to see if you're flattening the curve. So we're going to be looking at this data and see if we can see a flattening, which we think we're at, and hopefully a decline here relatively soon. So how do we reopen Kentucky? Closing the businesses and the medical community was very complicated. Reopening it is going to be even more complicated. So if you listened to Dr. Stack, our Commissioner for Public Health, when he was on Governor Beshear's presser on Thursday night, he tried to go into detail about how this is going to happen, but we have encouraged industries to submit report plans to us. We've worked with Kentucky Hospital Association, Kentucky Medical Association, the Chambers of Commerce. There's a task force of the different dental communities that's come together, so they can kind of give us some type of a plan of how they plan to reopen their business. I had a private business for 20 years. 3 of those years I was solo OB, and the rest of the time I did have some partners, but I've been trying to think in my mind, how would I reopen my practice? So the important elements that every business, not just a medical community, are going to have is social distancing of greater than 6 feet, universal source control by masking, and that's, we'll talk about that in a minute, but all the healthcare providers and the public needs to be finding a way that if they can't socially distance, they need that universal source control. Enhancing our hand hygiene, cleaning those touch surfaces, and then temperature checks and screening people for COVID-19, and then increasing testing availability and rigorous contact tracing. Contact tracing, it's kind of a new buzzword, like PPE is new to some people in the public, but contact tracing is something that health departments do all the time. Whenever there's a salmonella outbreak, a measles outbreak, a mumps outbreak, local health departments are contacting people. So you have to get the test, whether it's a specimen of diarrhea from a salmonella outbreak, or whether it's testing you with a PCR or one of the antibody tests, and we'll talk about that in a minute. So you have to know where the disease is. Then you have to isolate all the infected people, because if you don't isolate that person that's infected, then they're going to go out and infect. We already know that there are asymptomatic patients that can infect, but we want to see how can we make sure the infected people are isolated. Then we do the contact tracing and ask them who they've been in touch with. Have you just been in the building with someone, or did you spend a considerable amount of time in close proximity to them? Those people that would then be asked to quarantine for 14 days. So we're looking at, and I'm going to talk about testing here in a minute and expanding that testing. We need to find places where people can stay. Where do you put someone who doesn't have a home? Where do you put someone who can't really separate from the other people in their home? Where do you go when you have an ill family member, or whether that family member might be one of your patients' household members, and you really don't want that positive COVID-19 patient staying with your oncology patient. So looking at ways to have non-congregate settings where people can recover. And then we're working on our contact tracing plan. It's going to take a lot of people to do the kind of work that's going to be necessary to find the people with the infectiveness, find their contacts, and then make sure that those folks are quarantined for 14 days. The next slides I stole from Dr. Stack's presentation. These are all on the website. If you go to the kycovid19.ky.gov, I'll give you later. But this is kind of describes what we know in the governor's plan for reopening healthcare facilities. So we're talking about Monday, April the 27th, we can resume non-urgent, emergent healthcare services, diagnostic radiology, and lab services. Please notice this does not say elective surgery. That's not phase 1. But non-urgent, emergent healthcare services, diagnostic labs, and diagnostic radiology and lab services. So this includes outpatient. This includes healthcare clinics, medical offices, health department clinics, physical therapy settings, occupational therapy settings, any of those type of settings, and chiropractic offices, optometrists. The dental community is a little bit different because they have a different thing that they are having to deal with, because they will be aerosolizing viral particles in the mouth, the back of the throat. And so those folks are going to have some rigorous control for their staff and for their offices, and the surface contact cleaning is going to have to be pretty intense. It doesn't say here, open up on the 27th of April, just as you were practicing on March the 15th. Things will have to be different, as we've discussed before. Now, this guidance doesn't talk about long-term care, nursing homes, prisons, any other of those particular settings where there are already some guidelines in place. It just refers to these particular settings. So this gradual opening is going to try to be sure that we don't just open everything up and then we're back to where we started from, worrying about our healthcare providers, our healthcare facilities being able to handle a resurgence of COVID-19. Any way you can use telehealth. If anything positive is happening here is the emergence of telehealth as a very useful tool. It's not the end-all be-all, but I think anytime we can avoid having people get into the healthcare system until we can protect them with a vaccine, telehealth rather than in-person services, I think will be the ideal. We're still, the order is still not allowing people to visit other than end-of-life, vulnerable populations that have to have a caregiver for them to function, minors, those rules have not changed with this phase one. Traditional waiting rooms are going to soon be a dinosaur of the past. Commons areas, obviously there will have to be some commons areas, but those will be greatly underutilized compared to people sitting in their car and waiting to be texted that it's time for them to come for their appointment. And then the social distancing and trying to make sure that when people are waiting in line, there's a 6-foot separation. Before all this started, about a few days before this order went out, I went to see my physician, and there were marks on the carpet of where I was supposed to stand to be sure I wasn't standing in line too closely to someone. Another part of phase one reopening is that we all need to screen all healthcare workers and patients for their temperature and COVID-19 symptoms on arrival for every shift. I know that sounds pretty overwhelming, but it is something we have to do. In some of the investigations we've done where there have been pockets of COVID-19, I'm just struck by the number of people that are coming to work sick. Now, I have to be the first to admit, when you do solo OB for 3 years, and you work all the time, you are sick when you come to work. And I'm not proud of the fact that I did that. But this is a time for us not to try to be superheroes, but for us to be sure that we're not putting our patients and our other coworkers in harm's way. Please encourage your staff to stay home if they're sick. That this is how COVID-19 pockets start. And then once it gets started, it just spreads like wildfire. Plan for workplace sanitizing, good hand hygiene. Make sure it's easy for people to get to hand hygiene. I get a real kick out of on my desk, I've got a bottle that looks like a bourbon bottle, but it's hand sanitizer. It makes me smile on the times that there's nothing to smile at. And then make sure that you've got appropriate PPE to protect your staff while they're working. The PPE supply chain is loosened up considerably in the last 5 weeks. It is nowhere close to what it used to be. We have had shipments where we have ordered and wired money in advance, only to find out that the money came back because of the federal government needed it for another place rather than coming to Kentucky. Somebody knows somebody that's got a great deal on some Chinese N95s, and it turns out that those people are on the counterfeit list. So it has been a slog to try to get the appropriate N95s, the gowns, the gloves, the coveralls that people need. There is a website that your organization will be going to if they cannot get under the normal supply chain the PPE that they need. We do not want our healthcare workers not protected. So we have a warehouse where we store these things as they are purchased, and we have a committee that reviews the need, and we will help to supplement what people can't get through the normal supply chain to be sure all Kentuckians are protected in the healthcare community. Masks, everyone in the healthcare facility, and I know UK has already done this, must be wearing a surgical or a procedural mask. You are also, I know, asking patients to do that, and I think in private practices and other healthcare clinics, we need to do the same thing to prevent the spread. And then the last thing on reopening is we need to think about high-touch clinical settings, such as physical therapy and chiropractic. I know that as an oncologist, you are examining the patient, but this is a little bit more high touch than that. And so we're asking those particular facilities to go a little bit further. And then the next point is the high aerosol risk settings of dentistry, oral surgery, and anesthesia and pulmonary services. So I'm looking forward to see what the dental community comes up with their recommendations. Now the testing, I'm going to go over this really quickly because this is not my strength here, but we are very blessed to have Dr. Vineet Aurora and his team. We do have the Department of Public Health does have a state laboratory where we started to do the PCR polymerase chain reaction testing back the first week of March and diagnosed our first patient March the 6th in Kentucky. This identifies viral DNA. It tells us if someone's infected, and it is an NP specimen. I finally stopped saying NG specimen. We don't want an NG specimen, we want an NP specimen. Antibody testing is kind of the Wild West right now. As we've had a great need for testing, the FDA is doing clearing labs to do testing, and most of those labs have only done have only done laboratory testing and have not done the clinical trials we would normally expect for a serology test. Some of them are doing IgM and IgG. So if it's positive, you don't know, is this person got an are they IgM positive and they're actively infected, or do they have IgG because they had COVID-19 back the first week of March? But since you can't distinguish if this is IgG or IgM, your test result isn't very helpful. There was one serologic test that checked positive for any coronavirus. So if you had ever had any coronavirus, you were positive. This would certainly muddle your clinical decision making. So it's too early to know for sure which are usable and reliable tests. Dr. Aurora and his team are testing right now using our PCR testing and doing backup testing with the serology so we can find things that we can recommend. But at this point, we are still in the learning phase. So this is just a slide that most of you would already know that PCR testing, if it's recently occurred, you would want to get an IgM test, and if you got an IgG test, that shows that you've been infected sometime in the past. So what are we doing? Well, we are trying to support testing in hospitals, local health departments, doing a lot of long-term care facilities, doing a lot of work in prisons, and our behavioral health hospital in the state. And I'm sure you've heard about the Kroger and recently the Walgreens testing. And we're also trying to help the private sector ramp up, because we can't be purchasing and doing this forever. This needs to be something that's incorporated into the provider's office. And as I said, the antibody testing is resolving, as well as the point of care antibody testing. So everything I said about antibody testing before refers to the point of care as well as in laboratory. This is just a map because I needed something colorful, because it has been slides have been kind of boring. But all of these show you places where we have hospitals that are doing testing with our Gravity project, where we purchased some testing from Gravity Diagnostic in Covington, and we have an arrangement with UPS to do the shipping. So these are hospitals that are working in their communities to get more testing. The K's are the Krogers. So this is where we're trying to blanket the state, but obviously when you look at that map, there are still areas that don't have quick access to testing, and those all are in process right now. I wanted to mention the state-sponsored non-congregate shelters. We knew, as I said earlier, when we're doing contact tracing, that we are going to have some people that say, you're not sick enough to stay in the hospital, but you need 14 days of isolation. And the person looks at that provider and says, can't do that. My wife has cancer. My wife has rheumatoid arthritis and is on drugs that would make her susceptible to COVID-19. I live in a one-bedroom apartment with 12 other people in one bathroom. In a situation like that, we have set up 2 facilities to date. They just opened this week at Lake Barkley Lodge and at Lake Cumberland Lodge. And this will be a place where someone can go and stay in the lodge hotel room. They'll get 3 meals a day. There will be a medical staff on site. They'll come by and either have you check your temperature or check your temperature, check to make sure you have no worsening of your symptoms. And this will be a way for you to ride out those 14 days in a setting that will allow you to recover. And we will also be doing some case management for those folks that don't have a place to go home to. So going back to that org chart that I talked about earlier, we have our public health preparedness folks have been busy at work for weeks now. Our folks in the molecular and clinical chemistry laboratory at our state laboratory have been extremely busy, working 7 days a week. Our infectious disease folks who do the surveillance have been very busy, as well as our vital statistics folks, as we look at the deaths that are reported and we confirm that with death certificates. We also have our food safety folks. At the state level, we inspect the companies that make the food sources for us to eat, not the restaurant inspections like the local health department does. But we're working with some outbreaks of COVID-19 we've seen in those communities, and how we can not only prevent them in the workplace, but also in those communities, because often some of those communities are English is not a first language, and there are cultural differences that we need to be aware of and work very carefully with. Health equity, as I mentioned, is something that we are very targeted on to try to be sure that we do everything we can to prevent that disparity that we're seeing in cases and deaths. The budget people, there are all kinds of different streams of money that will be coming in, that have come in. They all have a different set of rules, and our budget people are kind of pulling their hair out over that one. Then HIV, there are some reporting of HIV hitting the HIV community being harder hit by COVID-19. We have not seen that, but we're staying on top of that. We're working with our chronic disease prevention group to make sure that our patients with comorbidities know the importance of making sure that they don't get exposed to this virus. And then the ultimate, what we're all waiting for is when our immunization branch can dust off our plans for immunization and start vaccinating people against COVID-19 when that time comes. When that happens, it will not flood the market. We will have a small amount of vaccine. We have to decide who gets that vaccine, who is it dispensed to, and we will have time to get that plan up and ready. So this is the COVID-19 website. If you have not been there, as I said, you can find some very interesting information about the COVID-19 outbreak in Kentucky. This is my email address that you can certainly email me. If I don't know an answer, I know who to ask. And if there's not an answer, I will tell you that. So I'm going to stop sharing my screen now and see what questions we have in the chat box. Dr. Northup?
So the first question is, can you please explain why cancer survivors are at more risk for COVID-19, particularly stage 1 cancer survivors?
No, I cannot explain that. I know that any comorbidity that challenges the body, whether it's diabetes or whether it's cardiac disease, that is something that this virus seems to thrive on. It thrives on the bodies of people that have this. And no, I can't explain that to you, but I know there are a lot of really smart people looking at that. Is there a genetic predisposition? We don't know.
While we're waiting for the next question, I'll just announce that Dr. Creed Pettigrew, a professor of neurology here at the University of Kentucky, will give COVID-19 grand rounds on May 1st on the neurological complications of SARS-CoV.
Great.
Do we have any other questions, particularly related to public health, reopening practices, those kinds of things?
Kenny, please send me a link to that grand rounds. I'd be very interested in hearing that.
I'll certainly do that. So while we're waiting, have you heard any plans for sort of strategies that the audience can use as they begin to reopen for increasing social distancing?
I think what you're going to have to do is a walkthrough. You're going to have to put yourself in that patient's head and say, okay, I have an appointment today. What's going to happen? Well, in my practice in Frankfurt, I was in a small office building, and someone could have sat in their car, and I could have just texted them, come on in for your appointment, and they could have come in. Having spent some time at UK, if you told somebody that and they were one of your cancer survivor patients or your current cancer patients, it's a hike to come from the parking garage to your facility, to your actual office. So you're going to have to try to figure out how long is it going to take them to get there. What do you do if they don't have a phone? How are you going to make that connection with them? Then you're going to have to say, all right, this person walks into the building, so then they're going to have to go through whatever screening that UK has. They'll get their mask, they'll come to your office. And then how many chairs are you going to have in your reception area? Because there really shouldn't be that many people sitting around. So you're going to have to make sure that setting is okay. You're going to have to make sure that there's hand sanitizer after they walk in the door, once they've touched doorknobs and other equipment. Are you going to have people sign in with a pen? How are you going to do that and make sure that's re-sanitized? Do you have adequate PPE for your staff when they bring that patient back? How often is someone going to clean a room? I mean, we clean the room, but you're going to have to be doing some really room cleaning between patients, which again is very different. Who's going to be responsible for that? Do you have enough cleaning supplies? I mean, we went there for a while that we couldn't get cleaning supplies and hand sanitizer on a bet around here, and now those supplies are better, and thank you to the bourbon industry for making so much of that free sanitizer to help get us through that time. So I think you're going to have to just really sit down with your whole team, because everybody's going to look at this with a different lens, and somebody's going to say, well, what about, and everybody's going to go, oh man, I didn't think about that. So it's going to be a real iterative process that you're going to have to go step by step by step. What's the patient going to be doing? What are we going to be doing in response to that patient? And how are we going to make sure that that patient comes to our office and doesn't leave in a worse condition than they came in? Terrible story about a man who died because the physical therapist that came to the home, and he had not gotten his test results back for COVID-19, but he evidently was having some symptoms. After he left, the next day called the family and said, gosh, my COVID-19 test was positive. His patient got COVID-19 and died. His wife got COVID-19 and his daughter got COVID-19. Now, they did not die, but that's one of the situations that you don't want to ever look back and go, man, why didn't we think about that? These are the kinds of things that you're going to need to think about.
What will be the strategy to test for the virus in asymptomatic Kentuckians other than contact tracing? I'm especially interested in businesses with lots of public traffic.
That's a really good question. And we haven't pushed asymptomatic testing because we barely had enough testing to test symptomatic people. But for this to be a workable process, we need to be testing asymptomatic people. And we haven't printed them yet, but I've even come up with a card that I want to give people at these drive-thrus. And on one side says, if your test is positive, you'll be contacted by your local health department for contact test tracking. On the other side, I'd like that card to say, if your test is negative, that means the minute and time that you had that swab collected, you did not have enough COVID-19 RNA in your system to be infective. But that doesn't mean that the next day or the next day or the next day, you could not be positive. So the negative is it's that old problem with that I learned in medical school. Don't order a test if you don't know what you're going to do with the results. If it's not going to change the treatment plan, don't order the test. So part of it is until we can test everybody. That's why I think the masks in public are important, so that everybody walking around, even if they're positive and don't know it, aren't shedding that virus to others. But we will start testing more asymptomatic patients, and then we'll have to do that contact tracing, like you said.
We had one request for you to put the Department of Public Health website up again.
Oh, sure. I'm happy to do that. This will stop. Yes. Yes. Sorry, I am a dinosaur, and it takes me a minute to do this. There you go.
Thank you.
There are videos on there. There are CDC links. There are documents that are Kentucky-centric that we've put together just for Kentucky. The slides that I showed you that Dr. Stack presented at the press conference yesterday are on there. There's information about price gouging. There's information about who do you call when you see people gathering and they're not supposed to be. There's a place that you can donate to the COVID-19 fund that the Lieutenant Governor is managing for people who are in need because of the just devastating economic times that we're having. There's a whole host of places of links that you can go to on that website.
Is there any information on the website or elsewhere about how we counsel our patients about the best kinds of face covering that they may be able to use? Particularly we have a lot of lower socioeconomic status families.
Yeah, about the face coverings, is that what you said?
Yeah.
Okay. Yes, my best friend that I went to med school with at UK just sent me 2 masks from Seattle because she's a retired internal medicine doctor with lots of time on her hands. So the cloth masks are very helpful for people to have spread control. So we're not out spreading that in the public. But the materials that those things are made from and the way they fit their face. Now, I spent 20 years wearing a mask like all the time, and these cloth masks are more complex to wear because they just don't fit the same. And the fabric is heavier, so it is a challenge to wear. And I worry about, there's one person in particular here at the department that spends most of the time adjusting that mask and spends most of their time I just want to say, just take it off. Just don't do that. But it'll take a while for people to get used to wearing those. So the cloth mask, I think, are a terrific idea for us to try to protect each other. But the surgical mask, watching us dole those masks out box by box, I'm just hesitant to have people wearing surgical and procedural masks unless they are in a hospital setting or in a healthcare setting where that mask is also protecting them. And that's where I think we need to be very clear that we need, surgical masks and face shields. We have a bunch of face shields. We've got a lot of Kentucky industry that are making face shields. Toward the end of my obstetrical time, I stopped wearing masks. I was wearing face shields all the time because that interaction was very important. They needed to see my face. They needed to hear what I was saying. But a face shield and a mask is an excellent way to protect yourself as a first responder of any stripe. So the N95s, I know in our local hospital, which I still have relationships with here in Frankfurt, very few people are wearing N95s unless they work in the COVID wing or the infectious section of the hospital. They're trying to save those N95s for a time that they may need it again. My concern is the second peak that I think we will have. I can't tell you when it's going to happen. It depends on how long it takes us to open state back up again. And I know people don't like to go back to the 1918 Spanish flu because medicine's different and the society's different and plumbing is different, but people's behavior is not that different than it was 100 years ago. And when someone says we're open, then people are going to start doing crazy stuff. And we're going to have a second spike. And hopefully, if we do, it will be such that we will have that adequate PPE. People will be ready, those plans will be in place, and it won't be that crazy drinking out of a fire hose that we had the 1st of March. It'll be, oh, we just need to reinstitute everything, and we'll hit it seamlessly the second time.
Any other questions from the audience? I'm not seeing any come up just yet. I'll give them another couple of minutes. Anything else that you'd like to leave us with while we're waiting to see if there's another question?
No, just stay tuned. If you don't watch Governor Beshear's press conferences, I'd never miss them because he has plans that include not just the Department of Public Health, but all different parts of the state. So he will present some of his plans on the afternoon press conference that we're not quite aware of, and it helps me know what my marching orders are going to be. I think today you're going to see some things happening probably. Dr. Stack, I thought, did a very good job yesterday explaining how opening will happen, but I think they'll probably build more on that as everyone gets ready for the opportunity to start getting back to their practice and caring for the patients they care for the most, and reconnecting with that staff that's like family that you haven't seen in a while. So stay tuned, watch those events, or read the events in the Herald Leader. They've done a very nice job reviewing everything that's been said, and hopefully we will be getting through this together in a really smart way that will help our patients and protect our lives.
Well, thank you very much. I don't see any more questions. Thank you for giving our grand rounds. I really appreciate it.
Thank you so much for having me. Stay healthy, everybody.